Hello, my fabulous future RNs. Welcome back to Discussions with Dr. G, the podcast where we turn terrifying nursing topics into hilarious life lessons so you don't accidentally send your patient to the ICU because you mixed up your heart rhythms. As you guessed, today we're tackling the greatest hits of cardiac rhythms. Yes, those wiggly squiggles on those ECG strips that you may have been avoiding because they look like modern art. Let's dive in before your patient's heart decides to drop the bass permanently. All right, so the basics, waves and intervals. Because before you can read the rhythms, you gotta know who's on stage. The P wave. This is your atria's way of saying hi. It's a tiny, polite bump before the real drama starts. And then you've got the PR interval, which is basically the polite pause, if you will. The electrical message hanging out in the AV node, it chills there for about 0.12 to 0.2 seconds before that electrical pulse heads to the ventricles. Then you have the QRS complex. This is your ventricle's big entrance. Think of it as the main act, ventricular depolarization, or the big spike. If it's wide or weird, you need to worry. Normal is 0.06 to 0.1 seconds. And then there's the T wave, which is the ventricle's way of just chilling out and resetting for the next beat. If it's tall, peaked, or inverted, potassium or ischemia is usually the one causing the issue. Oh, and the U wave? Nobody really cares about the U wave until you see it. Usually it's a sign of hypokalemia. So if you spot it, just remember that the U means you need potassium. Anybody paying attention? This has literally been the end of the alphabet. P, Q, R, S, T, and U. So now that you've got the basics, what happens when the rhythms go rogue? Let's talk about spotting abnormal rhythms. Sinus bradycardia, tachycardia, AFib, aflutter, and SVT, or supraventricular tachycardia. Sinus bradycardia is your slow poke heart. It's usually under 60 beats per minute. Sometimes it's just an athlete being, annoyingly healthy, but it can also mean trouble if your patient's dizzy or hypotensive. Sinus tachycardia, that's the heart on a caffeine binge. This is where the heart beats over 100 beats per minute, often thanks to fever, pain, or even dehydration. Now AFib, that's the atria throwing a wild party with no rhythm. No P waves, just a wavy bass line and an irregularly irregular rhythm. Why does this matter? Because AFib is a clot factory. If you miss it, your patient could be headed for a stroke. That's why rhythm recognition is so critical, not just for showing off during rounds, but for actual, saving lives. Aflutter, very similar to AFib, with the exception of how it looks on the ECG. Instead of no P waves or a wavy baseline that is irregularly irregular, you're going to see a sawtooth flutter in the waves, and that can be regular or irregular. This is way better with pictures. And then there's SVT, supraventricular tachycardia. Your heart suddenly starts racing like a startled cat with a narrow QRS and heart rates that can hit 250 beats a minute. Patients feel it, trust me. Palpitations, dizziness, sometimes even chest pain. Vagal maneuvers can help, or adenosine if you want to see the patient's eye go wide for a second. But always check if they're stable and that you have orders before you go pushing meds. Now, let's get into the real drama, life-threatening rhythms. VTach, torsade de pointe, VFib, and asystole. Remember, the V stands for ventricular. These are the ones that make your heart race, and not in a good way. If your patient has a pulse, you've got a shot with meds or cardioversion. No pulse, that's a code blue. Start CPR and defibrillate immediately. Torsade de pointe is ventricular tachycardia's fancy French cousin. It's all twisty on the strip, and it's usually because of low magnesium or drugs that mess with the QT interval. So if you see it, think magnesium sulfate IV and defib if they're pulseless. With ventricular fibrillation or VFib, that's where the heart is quivering like jello, with no output, no pulse, no chaos, or just chaos, lots of chaos. Start CPR, defibrillate ASAP, and I hope you've had your coffee. And then there's asystole. This is your dreaded flat line. No electrical activity, no pulse, just a straight line. Here's the thing. You do not defibrillate asystole. There's nothing to shock. Start CPR, give epi, and look for reversible causes. I can't tell you how many times I've seen new nurses panic and reach for the paddles. Don't be that nurse. So here's your survival hack. Always check the patient first, not just the monitor. Feel for a pulse before you scream code blue. If it's pulseless, VTAC, or VFib, defibrillate. Watch for symptoms, dizziness, chest pain, hypotension, and know your basics, your P wave, PR interval, QRS complex, T wave, U wave. When in doubt, call for help. All right, that's your crash course in the heart's greatest hits, minus the scary Latin lyrics. Remember, recognize these rhythms, save a life, and earn your badge as a rhythm reading ninja nurse. Stay sharp, stay sarcastic, and never forget, the squiggles tell the story, but your patient tells the truth. Until next time, keep learning, keep laughing, and when in doubt, check the pulse first.